Hello everyone, this is Chadi Alraies from SIF 2024 and we are with the 20th anniversary. I'm really delighted to be, as always, to be with Jonathan Schwartz. We always come to you with new structural updates, data, as well as new procedure and approvals. Jonathan,
Chadi, great to be back at
Yeah.
SIF. I think this is our 5th year doing it together now.
Yes, fifth.
So,
You're right.
Very happy to be
back.
here.
Thank you. So let's start with cusp overlap for aortic valve, because I think this is a topic keep coming back, especially for low and intermediate risk patients.
Yes, for sure. So TAVR, it's been interesting. Not only have the actual valves themselves been innovated upon, but sort of over time we've also learned a better way of implanting these valves. And this sort of stemmed from some differences between the balloon expandable and the self-expandable valves with regard to pacemaker rates afterwards. The self-expanding valves kind of predictably had higher pacemaker rates. The thought was that because of the way it's designed, it exerts a constant pressure on the bundle, and that can lead to both new left bundles and pacemakers. Not a huge deal. The pacemaker implantation is not that complex of a procedure, but if you can avoid it, it's nice to. The other problem is you sort of get into this gray area where, they have a new bundle, but they don't have complete heart block, so what do we do with that? So that's led to some studies about how to implant these a little bit higher. And the reason that we needed to do that was the way we did it before, you couldn't fully isolate all of the leaflets while you're implanting these valves, and so it was hard to see exactly how deep your valve was going in, because the depth is associated with the pacemaker need. And so cusp overlap is a technique that we use now where we can visualize exactly where we implant the valve, a little bit higher than we were doing before. It's been shown to have a much lower pacemaker rate.
Right. And this has happened, usually this is the vendor where they send you the images to tell you this is the best angles for the photo?
Yep, either the vendor can do it, or if you have good imaging at your own institution, they can do it as well.
And this is this is for both self-expanding and balloon expanding.
Yeah, so it's stemmed from self-expanding, and that's kind of where you typically associate this type of technique with. But some studies have been done looking at balloon expandable, same thing, lower pacemaker rates, even though they were somewhat lower already. But sort of the consequence is there's concern, and actually some studies have proven this, the coronary reaccess is a bit of a problem. We're sort of being able to account for that with some additional finesse with how we implant these, because we can control commissural alignment now. And so that allows to make sure that when you're putting your valve in, the access to the coronary, you have the greatest chance that you'll be able to get in. What we're not sure about fully yet is down the road when these TAVR prostheses start failing, when we start doing TAVR and TAVR, what does that mean for being able to access the coronaries? Also, just implanting the valve itself, you're almost creating a tube graft in some cases, and so we're just going to have to figure out what to do with that.
Right. Well, now let's shift gears to the tricuspid. Tricuspid is becoming a more kind of hot topic now, and mitral valve definitely have still some work to be done, but tricuspid started, especially after the approval. I think last month.
Yes, exactly. So the Edwards Evoque valve, somewhat surprisingly, got approved much quicker than I think most of us anticipated, which is great. It's now available commercially. The problem is we're not quite at the point where all the institutions are sort of ready to put it in. The production's a little bit slow. The teams need to be ready to do all this, and so there are a few commercial implantations that have happened, but the large, widespread use of it's going to be a little bit of time. So that's happened. The tricuspid clip, the TriClip from Abbott, the panel has given good remarks for it, and it's slated to be approved, but the approval officially hasn't come yet. We anticipate that sometime soon.
When do you think the best time to repair the tricuspid valve?
Oh, so that's something that we need to still learn. We really only have the 2 studies so far for transcatheter therapies that are randomized control studies, at least, between the Evoque valve and the tricuspid valve. They didn't look at them head to head, it was just versus medical therapy. And really, the inclusion criteria was more focused on anatomy and imaging as opposed to the part of where the patient's progression is in their heart failure. And so I think that's something that will probably come out later. Triluminate did have an imaging sub-study, which was great. We got some really good data from that, which I think will sort of help guide us a little bit as to the best time when to implant these valves or repair them, depending on dilation of the RV and reserve and things like that. So,
Yeah, because we don't know, like similar to the TAVR initially with extreme risk, just deploying a valve, hope for the best. I think now it's time to understand what kind of patient, what phase when the RV at certain diameter or level or the heart failure symptoms.
exactly.
Yeah.
I think one interesting difference for tricuspid here will be we don't tend to do isolated tricuspid surgeries really.
No.
And so I think I won't be surprised if you see the amount of implantation of these devices grow much faster
Yes.
than it has with TAVR.
Yeah, because we have a lot of patients echo, those fine, wide open TR is fine, we'll be okay.
Exactly.
But the LVAD is fine, but we need these patients. And even with the guidelines, is for surgical valves, the indication is if you're doing other valve, or you're going to do bypass.
Yeah, I think we're going to need a guideline update sometime in the near future here, but maybe a little bit more data, I think, before they incorporate things into the official guidelines.
Jonathan, always a pleasure. Thank you so much for being with us. Please watch the videos and others on SIF YouTube channel. This is Chadi Alraies from SIF 2024. Thank you.
Thank you.